In this video, I wanted to talk about several papers that I've been collecting over the years on placebo effect, and it explains one of the reasons that I'm very critical of non-placebo controlled studies and um, a little skeptical of studies that don't have a good placebo control. So let's go over these papers together. Placebo comes from the Latin word meaning "I will please," and it's just basically it's talking about some intervention or some drug that really is not supposed to have any therapeutic effect, but indeed happens to have a lot of therapeutic effect in studies, and you use a placebo to see is the drug that you're testing actually doing something more than a placebo would do. So this is a paper written back in 2008, mainly by a group out of Harvard. And let's read their introduction because it's kind of interesting. Aside from the provision of a specific therapeutic regimen, a medical encounter might elicit non-specific or contextual benefits, which are often called placebo effects. So experimental settings seek to contain these nuisance effects with placebo controls. Such non-specific effects in a clinical setting can be theoretically separated into three components. A patient's response. So they're saying placebo effects kind of are the result of three things. One, a patient's response to observation assessment. This is called the Hawthorne effect. Hawthorne effect is something from psychological studies that showed that just because people know that they're being watched, they change their behavior. And then the placebo's response to the administration of a therapeutic ritual, so placebo treatment. So part of it is patients may change their response because they know they're being watched. Part of it is the patient might respond to the actual pill or the ritual. And then part of it is the patient's response to the relationship between the patient and the doctor. Okay? So in this study, what they did is they looked at irritable bowel syndrome. So irritable bowel syndrome is a chronic functional gastrointestinal disorder characterized by recurrent abdominal pain and disturbed bowel function, diarrhea, constipation, or alternation in between. It's very common. It's one of the top 10 reasons for seeking primary care, and it accounts for almost a third of all consultations with GI specialists. And probably they estimate direct and indirect costs of over 40 billion in the 8 major industrial countries. So irritable bowel syndrome seemed a good disease because previous randomized trials of treatments have shown a large positive response in placebo groups. So in previous studies, 40% of patients got better from placebo. And so any intervention had to be larger than that. In this study, what they did is they found 262 adults, and they had him in they treated him in three different ways. One way was observation. So they just were told, okay, you're in the study. We're not really doing anything for you, but we're just going to watch you and kind of, see how you do. And they'll take the surveys and everything. The other group was the placebo acupuncture alone. So they got acupuncture, but not real acupuncture. It was like they were putting the needles in places that I think actually placebo acupuncture doesn't even actually have a needle enter the skin, and they put it in places that it shouldn't work. That acupuncture guides say that that's not the right place to put them. And then they had a third group where they got the acupuncture, but also the practitioner gave them a lot of attention and confidence and talked to them and basically had a good, bedside manner, essentially. So at 3 weeks, half of the patients were randomly assigned to continue in their originally assigned groups for additional 3 weeks. Okay. So then what they did is they asked them how they felt. Were they doing better? Were their symptom severity score, quality of life, relief of symptoms? And at 3 weeks, the global improvement scale was 3.8, 4.3, and 5.0. So the group that was just being observed was 3.8, and then so higher numbers better. The sham treatment was 4.3, and then sham treatment plus a lot of like talking and interaction with the practitioner was 5.0. So the proportion of patients reporting adequate relief from. So just by being on the waiting list, 28%, just by being in the study, these patients didn't have anything done to them. 28% of them felt like they got adequate relief from their symptoms. 44% in the sham acupuncture group had adequate relief, and 62% in the augmented group showed adequate relief. And so what this showed was that basically just by giving them a sham treatment, and then in addition giving them a sham treatment with a lot of interaction with the practitioner, was even more helpful. So their conclusion was that the interaction with the practitioner is a big part of this placebo effect. One of the reasons that placebo studies are kind of taboo, because like one of the questions is, well, if placebo works 62% of the time, why don't we just give people placebo? Why do we even bother to give them like actual medicine? Because 62% response in a placebo is pretty good. And the problem being is that in these studies, people don't know whether they're getting placebo or not, and doctors and scientists feel like they are lying to people by giving them placebo if we do a study where there is nothing but placebo. So the next paper was from 2018, and it's by kind of the same group, and they go over 4 papers that they did recently, and they call this open label placebo. This is a study where you give people placebo, so a non-functional drug or something that shouldn't do anything, and you tell the patient that it's a placebo. You tell them, hey, this is a pill. It's not supposed to do anything. It's just a sugar pill or a starch pill or something. It has no active ingredient, but we're going to give this to you for your symptoms. And then they said, if the patients know that it's a placebo, does it still work? That's a very interesting question. And so conventional wisdom would say, once the patients know that it's a placebo, it won't work because they'll know that it shouldn't work. So let's go over what they talk about. So One of Us has been investigated in 4 randomized trials of open label placebo, each in different conditions, each with over 60 patients. So, I mean, these aren't huge studies, but, they're pretty big, 60 patients. And they receive open label placebo. The pills are described to the participants as inert placebos containing no medication, plus usual treatment or usual treatment, and in one case, no treatment. So to control for provider interaction time, patients in 3 of the studies received information about both groups, had identical patient-provider interaction. So they took that part out of the studies. Everyone got the same amount of interaction, and they were assigned to either arm. Okay, so the first trial, again, was irritable bowel syndrome, included 80 patients followed for 3 weeks. Patients receiving placebo reported 60% global improvement, compared to 35% getting only the usual treatment. So when you told people that it was an inert drug with no medication, it still improved their symptoms by 25% over the usual treatment. And the second trial was with chronic low back pain. So chronic low back pain is also a very common problem that people go to doctors for. The patients randomized to placebo plus usual treatment had a 28% reduction in pain compared to 9% in the usual treatment group. So again, large difference, highly significant. P-value is 0.001. Third study was 74 patients with cancer-related fatigue. So these were cancer patients. They have a lot of fatigue, usually from their cancer treatment. After 3 weeks, those randomized to open label placebo reported 29% improvement in fatigue compared to 10% for the usual treatment. Fourth study was migraine attacks. So they had 66 patients. Patients reported 15% improvement in pain when taking the open label placebo and 15% worsening of pain. So that's a swing of 30%. So in these 4 studies, they consistently showed that even if you tell the patients that it's a placebo, it still works. It's still better than the usual treatment, which was shocking to me when I first read that paper. Here is another thing. So most of these things are about pain and fatigue, which are very subjective things. And the question is does a placebo actually have objective measures that can be checked? So asthma has an objective measure. You can measure their forced expiratory volume. In this case, they had 3 studies. So they had albuterol, that's a real drug for asthma that is known to work, placebo, or sham acupuncture, or no intervention. So 39 patients completed the study. Albuterol resulted in a 20% increase in forced expiratory volume, compared to 7% with each of the other interventions. So all the other interventions gave a 7% objective increase, whereas albuterol, the real drug, gave a 20% increase. That makes sense. However, patients' reports of improvement after the intervention did not differ significantly for the albuterol inhaler. So the interesting thing from this paper is when you asked people with asthma, do you feel like you're breathing better? Are your symptoms better? 50% in the albuterol inhaler group said that yes, they felt better. Placebo inhaler, 45%. Sham acupuncture, 46%. These were statistically the same. The only one that was different is the people that got nothing. They felt 21% improvement. This is the Hawthorne effect, 21%. They got no intervention. They were just in the study. And then this is an interesting paper published in 2008. This is looking at antidepressant medication. So what they did is they obtained data from all the clinical trials submitted to the FDA. So many of these were unpublished because they had negative results. So they were testing a drug with the placebo, and the drug wasn't significantly better than the placebo, so they didn't publish it. But they do submit all this information to the FDA, and it can be accessed. It's like public domain information. So what they did is they got all the trial data and looked at it. And what they did is, I think this was like a ridiculous number of patients. It's like 15,000 or something. It was a large number. Okay, so what they found though, let's do the conclusion. Methods and findings. So what they did is they got all the clinical data. Then they used meta-analysis techniques to assess for linear and quadratic effects of initial severity. So basically, they looked at how severe were people's depression, and then they basically looked at compared the drug to the placebo as a function of initial severity. So basically, at moderate and low levels of initial depression, there was no difference between placebo and drugs in all these studies. And then there's only a small difference for very severe depression. And they reached clinical significance only at the very severely depressed category. And so when they did the analysis, what they found was that the relationship between initial severity and antidepressant efficacy is attributable to decreased responsiveness to placebo amongst very severely depressed patients rather than increased responsiveness to medication. So it's not that the medication actually worked better in very severely depressed patients. It's just that placebo worked less well in the very severely depressed patient. So it seems like when you're very severely depressed, the brain just can't process the placebo for it to work as well. Okay, so this, since I'm a surgeon, the most interesting papers that I found were about surgery, and I found it crazy that these studies were even done, but great. What they did is they did sham surgery. Okay, so let's go to the first one. A controlled trial of arthroscopic surgery for osteoarthritis of the knee. So a lot of people have knee pain, and one of the things that orthopedic surgeons did, and probably still continue to do, is they offer arthroscopic surgery. That's where you put little ports in the knee joint, and you irrigate it, and they find like the cartilage is a little rough, and there's some pieces of cartilage in the meniscus or the disc that need to be trimmed up, and so they'll use a little machine to trim it up and smooth it over, and which made sense. The orthopedic surgeons would go in there and they're like, this knee joint has a lot of these rough edges in the cartilage, and if we smooth it out, it'll probably make people feel better. And indeed, they did that for many years, and people uniformly said, I feel better. My knee pain is much better after the surgery. And that was just kind of accepted practice in orthopedic surgery for a long time. Like no one questioned it. Because it just made total sense. People have knee pain, their joints look weird. You trim it up, make it look nice, and then people feel better. Of course, that works. Then someone decided to maybe it's not the surgery that does anything. And so what they did is they enrolled 180 patients, and they either had arthroscopic debridement, so that's the usual treatment, and someone said, maybe it's just irrigating the joint with all the fresh saline that helps. So that's the arthroscopic lavage. And then while they were doing this study, someone suggested, how do we know that it's anything? Maybe it's just all placebo. And so a third of them got placebo surgery, which means they just got the incisions in the skin, but nothing ever entered their joints, and they never got any irrigation or anything. So patients in the placebo group received skin incisions and underwent a simulated debridement without insertion of the arthroscope. So they didn't do anything. They just kind of made the incisions and kind of placed the arthroscope in the incision, but didn't go into the joint, and just kind of what they actually did is they played a videotape of the actual surgery and just sat there and watched the videotape, so that the PACU nurses, the people in the post-operative care unit, didn't know who got the sham surgery and who got the real surgery. Because if they didn't do that, the people who came out really fast, they would know had the sham surgery, and they might treat those patients a little differently. So just so that everyone would treat them the same, they just made the surgery length the same. And then patients and assessors were blinded to the treatment group. So the patients didn't know, and the people who were checking their symptoms didn't know. And the results are, at no point did either of the intervention groups, so that means the full surgery or the lavage, at no point did they report less pain or better function than the placebo group. So essentially, they were all the same. Yeah. So placebo, lavage, debridement, they were all the same. And so they did a pain scale, and the higher score indicates more pain. So placebo group, 48.9. Lavage group, 54. Full surgery group, 52. So actually, the people had the least amount of pain was the placebo group. So in this controlled trial involving patients with osteoarthritis, the outcomes after arthroscopic lavage or arthroscopic debridement were no better than after a placebo procedure. Yeah, this was basically mind-blowing. Someone did another study in 2017 doing on shoulder surgery. So this is shoulder pain, and this one is, they did a trial at 32 hospitals and 51 surgeons. So this one is a small group. It was in one place, and I think they only had one or two surgeons. So they were like, maybe it was just them. This one, they did 51 surgeons and 32 hospitals. So it can't be just like that hospital or that surgeon. And they did basically arthroscopic shoulder surgery. What did they find out? So they assigned 313 patients to no treatment group. So 106 got decompression surgery. That's the full thing. 103 got arthroscopy only. That way they were just looking around and lavaging. And 104 got no treatment. All right, so what did they find out? Mean difference versus decompression, mean difference versus arthroscopy, but these differences were not clinically important. So surgical groups had better outcomes for shoulder pain and function, but this difference was not clinically important. It didn't reach statistical significance. And the surgical decompression, so the actual full surgery, appeared to offer no benefit over just looking. So just looking alone at it was just as good in all measures as full surgery. The findings question the value of this operation for these indication, and this should be communicated to patients during the shared treatment of the decision-making process. So they found out, doesn't work. This was a really huge study called the Orbita study, published in 2017 in The Lancet, which is a very well-respected journal. This was a blinded, multi-center, randomized trial of percutaneous coronary intervention. This is cardiac stents. Okay, so in this study, what they did is they checked, does stenting the coronary arteries help people with stable angina? Stable angina is people that have chest pain when they exert themselves. So we know that stenting people when they have a heart attack helps them. That's clear. And then they knew before the study that if you stented people that have coronary artery disease in people that have stable angina, those people felt better. They felt like they could exercise more, they had less chest pain. So this is what all cardiologists did, and it made total sense. You have a blockage in your coronary artery that feeds your heart. You have chest pain when you exercise, when your heart's under load. Of course, when you open up the artery, they're going to feel better, right? And so they did this for years without questioning it, really, because they had study after study that showed you do the stent, that people feel better. And then another person would put out another study. You do the stent, people feel better. So of course it works. No one did a placebo-controlled study until this study. And so in this study, they decided, hey, you know what? We should do a placebo-controlled study. In one group, we'll give them the actual stent. In the other group, we'll just look up there, but we won't put a stent in. So they enrolled 230 patients. 105 of them got a stent, and 95 got the placebo. And some patients dropped out. So 30 patients dropped out. They only had 20. So the mean area of stenosis was 84%. So these people, on average, had 84% of their coronary artery blocked. So it's a high-grade blockage. So you would think opening that up with a stent is going to make them feel way better. And then what did they find out? There was no significant difference in the primary endpoint of exercise time increment between the two groups. So the way they tested these people is, let's go look at the methods. Okay, right here. Cardiopulmonary exercise were done with the Quark CPET breath-by-breath metabolic analysis. They're both blinded to treatment, did all tests. The test was continued until the development of limiting symptoms. So what they did is they put these people before the study on a treadmill, and they had them walk faster and faster until they got either angina, chest pain, or dyspnea. They couldn't breathe, or they just got so tired they couldn't do it. Heart rhythm or blood pressure abnormalities, or marked ST segment elevation deviation. So that means on the EKG, it looked like their heart was getting ischemia. So they did that before and after the treatment. And then what they found out is it didn't make any difference. So the sham treatment, people felt after they got no stent and they got the sham treatment, people could exercise longer, just as much as the people that got the stent. And this was a kind of an earth-shattering finding in the field of cardiology. This is a systematic review of a bunch of these sham-controlled surgical and invasive procedure studies. They found 55 studies, and 39 of them had enough data for them to do systematic review and secondary analysis, and they found out that for surgeries that were for pain-related conditions, so like knee pain, shoulder pain, back pain, that kind of stuff, basically sham surgery was just as good as real surgery. And then for weight loss, um, it was only just marginally better. Real surgery was only marginally better. But if you had something like GERD, which was an actual a physiologic process that they're stopping, then there was a significant difference. So I think all these studies put together, when you look at them, show that things that look good on studies that are not placebo controlled may not be because the drug or the intervention actually works. It may just be a placebo effect. And so until you get a placebo controlled study, you can't say that the thing that you're doing is actually helping you or helping the patients. The drug may just be a purely placebo effect. So that's why I'm very critical and skeptical of studies that don't have good placebo controls and good randomization. So I hope that this helps people understand why placebo-controlled studies are so important when looking at medical studies. If you have any comments or questions, please put them below.